My name is Tracy Goodman. I'm the Patient Services Coordinator with Arrhythmia Alliance. Today, we are presenting Living with SVT, and I am joined by Dr. Shen and Dr. Chima. They are joining us from the Mayo Clinic College of Medicine in the Department of Cardiovascular Diseases in Arizona, in Phoenix, in the USA. Thank you.
Thank you so much, Tracy. Today, we're going to be presenting the topic Living with SVT, and we hope that the viewers will gain some benefit from our review here. So what causes SVT? Well, SVT, or supraventricular tachycardia, is an abnormal heart rhythm that overtakes the normal rhythm or normal conduction of the heart, which starts with the SA node and activates throughout the two top chambers of the heart, goes through the AV node, and then activates throughout the two bottom chambers of the heart. So SVT is an abnormal heart rhythm with rates that are greater than 100 beats per minute at rest, and there's multiple different types of SVT. So you can have inappropriate sinus tachycardia, atrial tachycardia, atrial flutter, junctional tachycardia, something called AVNRT, which is a mouthful, but it's atrioventricular nodal reentrant tachycardia, and an accessory pathway, which we have named AVRT, and that's a reentrant form of tachycardia as well. So just to illustrate two of our, when we talk about SVT, the more common ones that we refer to, AVRT is a circuit that includes an accessory pathway, and basically conduction moves down that accessory pathway and back up to the top chambers, and that's how the tachycardia can persist. AVNRT is a smaller circuit, usually in the right atrial side, so one of the two top chambers, and that circuit kind of moves around the AV node that I had outlined before. So what symptoms can patients have with SVT? Most often, patients will describe palpitations. They can feel some dizziness, shortness of breath. Sometimes they can have some chest pain, especially if there is some underlying ischemic heart disease or coronary artery disease. When their heart beats fast enough, they can experience some chest pain. They can have some fatigue. So if the tachycardia is ongoing for quite some time, they can experience some fatigue. Syncope is uncommon, but it is a kind of a red flag symptom that we look at very closely in heart rhythm. Other symptoms that are interesting because of the physiology is frequent urination. There is a enzyme that's released from the two top chambers of the heart when the tachycardia is ongoing that causes increased urination. Neck pounding. In that one specific type of tachycardia, AVNRT, you have the two top chambers and the two bottom chambers contracting almost simultaneously. And that causes some neck pounding because now the valves between the heart are closed and pushes the blood back up where they can feel it in their neck. And of course, a lot of patients can experience a sense of anxiety when they feel all of these symptoms. So when do we treat? In heart rhythm, we really look at three key factors. The first is severity. How bad are the episodes of tachycardia? Are they very frequent? Are they very long? All of these play into our decision making. And of course, are there any adverse consequences? So if I can go into that a little bit, Some tachycardias, when the heart rate is very fast for long periods of time, can actually lead to weakening of the heart muscle, which can cause what we call a cardiomyopathy. So the heart is no longer able to contract as vigorously as it does when it's not in that tachycardia. So these are all things that we look at when we make the decision of when to treat. Now, one thing that we do instruct our patients when they have tachycardia that is not very frequent, not very long when it comes on, and not so severe, but they do feel those palpitations, is we teach them how to do Valsalva maneuvers. And this is really bearing down, almost like you're having a bowel movement, but bearing down and trying to increase the pressure. And that actually can help to terminate these, some of these tachycardias. Carotid sinus massage, we will also teach them how to do that. That's a technique to definitely learn from your provider, where you actually massage the carotid body, and that can also help to terminate the tachycardia. And of course, patient preference. So what would the patient like to do? For us, ablation as a first-line therapy for majority of these supraventricular tachycardias is curative. So success rates are greater than 90%, and 97%, I put an asterisk there, that is usually for typical atrial flutter that we can achieve that success rate. Medications can be used for patients who are unable to undergo an ablation procedure. It is an invasive procedure. So if they cannot undergo it, or if they prefer not to, we can use medications. These are called antiarrhythmic medications. And the downside is they can be pro-arrhythmic in some patients. In some patients, they are also contraindicated if they have other comorbidities. Well, with that, I hope that this review has been somewhat helpful. And Tracy, I'd like to ask if you have any questions for us.
Thank you, Dr. Shima. That was fantastic. Really, really informative. I do have a couple of questions that we've received from patients, if that's okay with you both. My first question would be, is there a particular age when SVT will be presented or when it can begin?
Just perhaps take on the first question, and also just a couple very quick comments regarding Dr. Chima's very informative and concise presentation. I always, when I talk to my patients, once we learn the patient has SVT, and I try to reassure our patients that supraventricular tachycardia, SVT, is not a life-threatening arrhythmia, and we have many options we can treat. So this way, we kind of get the patient to start to be a little bit, at ease and not to be too concerned about that. And to answer your question, Tracy, about the specific age, the age actually with SVT can start even during infancy, sometimes even in uterus. And so the supraventricular tachycardia can start at a very young age, then of course during adolescence, and as the individual gets into the adulthood. So usually that these patients are brought to our attention because the patients have a variety of different types of symptoms, as Dr. Chima summarized. And so to answer your question, as supraventricular tachycardia, not life-threatening, and can present really at any age.
Thank you. Thank you. Also, my other question that we've received is, can it be misdiagnosed? Can it be misdiagnosed as another condition or be missed at all?
So I will speak to that, and I think there is sometimes a misdiagnosis. One of the symptoms that I mentioned was anxiety. So a lot, I would say that there are some patients that experience anxiety, and some providers may misdiagnose because it's not been captured on an ECG yet, that perhaps the patient is having episodes of generalized anxiety or anxiety attacks. And these may in fact be episodes of supraventricular tachycardia that may be causing some level of anxiety in this patient. In that case, discussing with your provider and letting them know how often you're having these symptoms, and possibly wearing an event monitor or a heart rhythm monitor can be very helpful, because we can definitely see what during those episodes of heightened anxiety, is there an arrhythmia present, or is this actually more of an anxiety issue entirely in and of itself? So that I will say that in some instances can be misdiagnosed.
If I may just make a couple comments as well. The diagnosis of supraventricular tachycardia, and when it comes to the tachycardia that can be recorded on a monitor, on a rhythm strip, or on an electrocardiogram, the diagnosis is pretty certain. And that can be made by internist, cardiologist. Most of the physicians can really make that diagnosis once the documentation is made. The challenge sometimes is the symptoms when the patient present to us, because as you saw the list of symptoms, and those symptoms can be very specific at times for supraventricular tachycardia, but other times can be non-specific. For instance, a person has a little palpitation, and what does palpitation mean to one patient versus another, and what does the palpitation mean to the physician? And so I think a correlation of the patient's clinical presentation, the symptoms reported by the patient, to a documentation is the key. And then the second point, as Dr. Chima already mentioned, today we have a lot of advanced technology. We can really capture these events, and depending upon the frequency and duration of these symptoms. And so the earlier days challenge was because the patient's symptoms, not all the time. The symptoms can be intermittent. So it's hard to catch if a person has the symptom, let's say once every couple of months. How do you catch that? But today we have longer ambulatory recordings. We have even some of these watches and computer software that we can download to the cell phone. So all of these that would allow us to document the patient's symptoms to the recorded rhythm strip, then the diagnosis can be pretty certain.
Thank you, Dr. Shen. During the presentation, Dr. Chima touched upon a couple of ways of treating SVT episodes when they happen. Is there any way you could explain, is this something that should be advised by the doctor before trying, or is it something all about self-management? What's the best way of doing it?
You know, it's funny, we'll have patients come in to us and describe these episodes, describe these symptoms, and then tell us what they do to terminate the episode. And that's actually quite a helpful piece of information from our standpoint. So patients are able to figure out this Valsalva maneuver when they bear down, when they put cold water on their face, when they drink cold water, these sorts of things that help them and help terminate the episodes. But definitely the patient should be seen by a provider. The first step is to be seen by a provider and to have a 12-lead ECG, so you have a definitive diagnosis. Mm-hmm. And then, of course, discussing with the provider treatment options.
Perfect, thank you.
So for the acute episode, I think the first thing is really, as we first evaluate the patient, is always reassurance and tell the patient don't panic. And then the couple maneuvers, as Dr. Chima has nicely summarized, the Valsalva, bearing down, or carotid sinus massage. These maneuvers can be effective in 50–60% of the time and stopping most common supraventricular tachyarrhythmias. And then the next phase is, of course, if the patient is very symptomatic and the tachycardia doesn't terminate with these maneuvers, then usually we would suggest in a very symptomatic patient, and in the States, I think similarly to the UK, in the UK, that coming to the emergency room, the emergency department, they are very effective ways of stopping these supraventricular tachyarrhythmias by an intravenous medication called adenosine. And then on a long term, as Dr. Chima summarized, really patient's preference, patient's understanding of the particular type of arrhythmia, and then making a decision with regards to long-term medication, the long-term therapy, and whether it's continual observation in a very in a situation that's very infrequent, or considering medication or ablation. But by the time that gets to the decision of ablation, usually a patient is referred to the specialty practice of cardiology and electrophysiology. The practice is very similar here in the States to UK.
Okay, thank you, Dr. Shen. My final questions really is something that you've just mentioned, is the ablation procedure, which is also a very highly effective treatment option. Is this a treatment that's offered to patients as a permanent solution to their symptoms? And is there a good time to have the procedure? So for instance, in the early stages, or can it be offered to a patient at any point in their patient journey?
So I will say one thing, and I'm going to hand this off to Dr. Shen. Of course, taking into patient preference, this is usually the class 1 recommendation for many of these supraventricular tachycardias is to ablate. And the reason why is because we have such good efficacy in curing and getting rid of this tachycardia. So the goal of ablation is to cure. Very, very infrequently will you need a second procedure. But Dr. Shen, I do want to let you take the end of that one.
Absolutely. So I always kind of back up a little bit, since I have come through the years when we first started ablation back in the early 90s to where we are today. And for patients who would like to seek more information, and today the ablation most times for supraventricular tachycardia is conducted by catheters that we insert through the veins into the heart, and then we induce the patient's supraventricular tachycardia, and then we use the terminology of mapping, and with the goal to figure out exactly what type of supraventricular tachycardia, as Dr. Chima summarized in one of the nice slides. And once we confirm the supraventricular tachycardia while the catheters are in place, and then we can be actually very precise in eliminate the particular trigger or a particular electrical circuit that's responsible for the supraventricular tachycardia. In the past 30 years, we have accumulated a lot of experience, data, and evidence through a large patient population, even comparison studies with catheter ablation versus medications. With all of those evidences as the background, today, according to our practice guidelines, and whether it is the US guidelines or European UK guidelines, in a patient who has recurrent and symptomatic supraventricular tachycardia, ablation is the treatment of choice. And the reason why that recommendation is made is because ablation efficacy, as Dr. Chima summarized, that most times in experienced centers, that success rate should be better than 95%, with less than 2 to 3% recurrence rate among those patients who were first to experience success, and the major complications actually is no more than 1 to 2%. And so in a person who is symptomatic with recurrent supraventricular tachycardia, we do recommend ablation as the treatment of choice. But then there are always exceptions, as Dr. Chima nicely summarized today. I think the patient's input and the understanding of the pros and cons, and then eventually reach a shared decision with the healthcare provider is really the key. And then medications can be moderately effective as well. Of course, they carry some concerns of side effects and also how long, really to use these medications. And but for most SVT today, that the current, the practice experience and the outcomes suggest it's a highly successful procedure, curative in many young patients, which translate to long-term, very favorable outcome.
Thank you. That concludes all my questions today. You've both been very helpful, and I'm sure this will be a very informative video for everybody. Thank you.